Pleasure to be here. Honor to present sort of the preliminary stuff of where we've come to in a short while. I guess when you look at the whole grand scheme of 100 years ago, the punch biopsy, and where we've evolved to in terms of our surgical management is quite impressive. Slide advancer. Oh, just the mouse. Okay. So I'm kind of tasked now in the next 10 minutes looking at some of the practicals. John did a great job taking us through the guidelines, how he works up a patient, and I think just to sort of iterate a few of those key points, moving toward what are the things that we should be thinking about looking and addressing and selecting between the various myths. Here are some of my disclosures. Working with some of the companies for BPH and some of the clinical trials with ZenFlow, Proverum, now with Urology. I guess the first thing to think about is, the tsunami is coming. There's a wave that's coming on board that in the next 10 years, not just the global, but US-based, if you look at men over the age of 65, will double or triple. That's the facts. And with it, if we can consider, workforce in terms of what we're doing in terms of training residents, will there be enough staff, people to manage these patients? And if we look at the AUA census, this is some work methodically done by Dr. Klaus Rohrburn, taking what we all click on those AUA censuses, and he kind of took that data and broke it down. And if you're interested, it's about a 52-page document, but he went ahead and sort of did the following, which is he looked at what's that mean age of the urologist, and we're looking at about 50% of urologists out there are 50 plus. And then if you look at the number of workload, well, how many visits are they doing per year? It's about 2,500 to 5,000 encounters per year. Now, if we figured out and said that every one of those male patients with LUTS or BPH need to be seen at least once a year, well, guess what? That would, in the lower bracket, be 120% of their current practice volume. So technically, there's no way we're going to be able to manage and continue writing scripts and so forth the patients that are coming our way. So we've got to find solutions to help us with regards to managing or treating BPH coming up. John did a great idea that not everything with LUTS is BPH, which unfortunately a lot of primary care, I'm sure we get to see, is patient not doing well on Flomax or double dose Flomax or Zatrol, and you work them up and maybe they have overactive bladder, nocturnal polyuria, what have you. So I think the key thing is, LUTS doesn't always equal to BPO, and sometimes BPO also coexists in about 30% of patients with overactive bladder. So making sure that it's not always a one and done, and make sure that you take the time to go through those workups to not get yourself into a situation where you're working up a BPH and you realize that they have a urethral stricture. So take the time, listen to your patient, do your appropriate workup. I think this just reiterates what was mentioned by John with the guidelines. And the thing that the guidelines doesn't really do, and I'm sure we've all already adapted to it, but we have to listen to our patients. The guidelines do not talk about patient values or expectations. So it's really important, are they looking to father a child? I've had some 70-year-old patients remarried and they have a very active younger partner, so that's very important. But we sometimes take for granted or we don't listen to them, especially in our Canadian system, the public sector, we're about 6 or 7 minutes per patient. So you don't really get to dig into those kind of questions. But I think that's quite important, and either online surveys or other things that are going to be done to help shorten that visit to make sure that you capture that information to help address those values. So, certain patients hate medications. I saw a patient last week and he's on medications. It's doing good, but he keeps falling. He's got early Parkinson's and the alpha blockers cause significant dizziness. So again, that is a simple little thing where just when he stands up, that postural hypotension really drives him crazy. So he wants to get off meds. His flow's not bad, but again, these are things that are going to help drive the needle and understand what they're looking for. And then a big thing, again, I think it's been like 10 years, I've been trained. My first BPH surgery was Dr. El Halali teaching me how to do a hole-up. And I did that for 3 years before I learned how to do a TURP. So I still hear him in my brain. This is before the guidelines ever changed. We did ultrasounds on every patient. He wanted to know what that anatomy was. And he'd always make the comment that for prostate cancer, if you have a PSA slightly elevated, we'll throw the kitchen sink at them. We'll do biomarkers, we'll do MRIs. But for BPH, to get as you said, wave the finger, it's not a great tool, especially after 40, 50 grams. So using ultrasound, and this is something that I've been exploring for the last 5 years, easy, single cost, low risk for you or the patient in terms of not radiating them. And you can get a lot of information, not just in terms of the size, dimensions. If there's stones, you can check bladder wall thickness, which we don't even talk about, because really at the end of the day, we're waiting to the end. In Canada, we wait till they have terrible bladders, then we manage the bladders after. And then elastography, really cool stuff. And I think there's a lot more we're going to start learning. And myself, Dr. Chugtai, and a few others, we're doing some research now looking at MRIs. We have PIRADs, but do we have any MRI BPH scores that will tell us, hey, this is a really stiff prostate. Maybe the steam won't work too well. So these are things I think we're in infancy. I think there's a lot more data and imaging that we can do. And this is a patient that was referred to me for a quote-unquote 50-gram prostate. Well, guess what? It was 130. And we had a nice big juicy intraprostatic protrusion here, medial lobe, and obviously the changes of management will be addressed by that volume. And some people say, well, the transabdominal may not be as great as transrectal. Well, we studied that in a series of patients, almost 100 men, TAUS versus TRUS versus radical prostatectomy specimen. And you can see there the curve was pretty linear across the board. And the key thing there is that you can pick up with transabdominally all medial lobes. So again, this is my Canadian experience in the past. Prior to POCUS, I just have to write a prescription. The patient have to go get a visit, get it done by a technician who does not tell you the results. I don't know if this is in the States too, but if you ask a technician what the results are, no, your doctor will tell you about it. Okay, fine, they'll leave. The technician has to be, type it up. It's transcribed. It's then faxed over to our office. The patient has to make another visit with me, and then they get to see them to go over those results, which I don't remember all the details. I have to go back and find out what his IPS says. So again, that takes, in the Canadian system, several weeks. Now that's a 2-3 minute extension of my physical examination. I can right away tell them, what's going on, save cost, anxiety, build trust, potential additional revenue. And other things that we're going to do capture information on is the use of AI and different device that we can have to our patients. So ProudP, has anyone in this room heard about that? So it's using this app that you literally have on your phone to the patient. He can put it in front of his toilet, and as he's urinating, it'll generate a uroflow. And it's also a 24-hour diary that you can capture what else is happening in a 24-hour period. So again, it's a free app, and I believe there's something that you can do, and you can bill for it in the States, and we can in Canada. So anyways, the idea is that I think with MIST, it comes aboard, a perfect timing of a storm that's coming our way, that we can have safe treatments and have good patient experience, and I think relatively good outcomes. We'll cover some of those in the next lectures. And really no loss of sexual function. The whole idea in the past that drugs and surgery, it's a cost of what you're going to do, and that was just something that we had to deal with and just expected. We didn't even bring it up. But I think that's the day and age now that we're 2023. We have a lot of options. We have to personalize those care. Much more than I remember my radical prostatectomy discussions. You have radiation or surgery. We had that talk, you guys, yesterday. But BPH now becomes a long discussion. We got to dig through them. So currently, we have 4 options. I added the 4th one. We're only going to be talking about 3 today, but the UroLift, you got Resume, you got some steam, you got a stent, a nitinol stent. We call it Stents 2.0 because Urolume stents from 10 years ago, if anyone had put them in, probably scared you, so you probably don't want to go back there. But yes, I see some heads. But things are changed because it's a lot less metal. The shape is different, and we're using nitinol. So we got the I-10, a temporary one, and now the most recent, the Optilume. So perfect. I got the 2-minute warning, and we're perfect timing here. So these are the other stents. Here's another tsunami. A lot more stents are being studied right now. ZenFlow is probably the one you're going to hear about next. So kind of like if you went to a cardiologist, hey, you're right there in front of your patient's prostate, you're the cysto, you can pull off the shelf this little device, squeeze it in. It kind of looks like a spiral of your kid's homework book, and it sits in place. There's 3 different sizes. And so the ZenFlow ZenCast study will be maturing to 2 years by next year. Is it going to go off every 30 seconds or? It's nice, but it's not annoying. And you got a few others there too, which we can dig into, but just know that there are other stents on board. So here's my bucket list. If you're coming into a BPH, these are the things that are in my mind I want to capture. I want to know patient expectations. Do you have a catheter? Well, guess what? Probably I-10 is not going to be the best choice for you. And ejaculation. If they want 0% ejaculation, we're going to have that discussion during Resume. There are reported patients with Resume that they're going to impact their ejaculation. You don't see that with the I-10 or the UroLift. Recovery time. Are you an Amazon Now kind of guy? Do you want results tomorrow? Don't get Resume. You're not going to like me for the next 4 to 6 weeks. So all these things, and looking at costs in a Canadian perspective, well, every UroLift costs $1,000 in Canada through distributor. So if you're going to put in 6 or 8 sutures, your base before other costs are $8,000 or $6,000. Whereas the Resume handpiece is $2,000 Canadian dollars. Well, we can have up to 15 treatments. So the cost is another aspect. And a hard one to do too is their tolerability to pain, right? You're going to go into a procedure, you have to kind of figure out whether we're going to have different types of anesthesia. Again, anticoagulated, bladder function status, the whole anatomy of the prostate, not just the volume. I think there's other things that we can pick up that we don't always appreciate with a flexible cysto, the high bladder neck, right? The tight bladder necks, the presence of those median lobes and how much it goes in. So the wise words of Arnold Schwarzenegger, it's not a tube. The urethra is a not a cylindrical tube that like the urolum that looks at. It's a slit. There's different heights. And so those are other factors have to be considered into that. So I think our anatomy of not just the prostate, but also the intraprostatic urethra should be better qualified. My dream is that we're going to find like a cast one day, like for your teeth or for your foot if you're going to do orthotics, and then you can design a stent based on that. Sounds wacky, but I think one day we'll see that. Those one size doesn't always fit all. And then the physician factors, the idea of doing a T-mist. So we're talking about mists, but Dean, Bill Allen, a few of us call about T-mist as an off-the-shelf solution. Do I need to buy a special pediatric bronchoscope? Do I need to buy a $35,000 Canadian Resume computer? Or is this going to be something I can just pull off the slit and it's ready to go? So with that, I'll jump ahead to the conclusion. So at the end of the day, know your numbers, know your patient. Set expectations, that's a crucial one. If you're really going to take the time to get into these, you have to really make sure the procedure is really quick for us, but to the patient and the recovery can be different. Make sure you do that to really personalize their care.